I'll be right with you guys.
Okay, thank you. No rush.
All right. All right. Yes, I was the test. um, the one I had on there for ditch toxicity with the infant. The reason I put that on there is you guys have had farm, you've had med surge, and Dig is a big drug that's on your NCLEX. I dropped it, but you guys should know digoxin toxicity. Okay, you guys cannot forget what you've already learned. So I did drop it, but yeah, you guys should have known your ditch toxicity. The other one was I dropped the difference between the encephalitis and meningitis question because you guys were getting them mixed up. Um, and then the priority for meningitis. I took two answers. I probably shouldn't have, but I did. Yes, we talked about seizures with meningitis, but you guys have to pick the priority. It said what was the priority thing that you had to do for that child with meningitis. Start those antibiotics. That was the priority. We actually did all four of them. But the priority is got to be those antibiotics because the child just gets worse and worse without them. Okay. Um, the other one that I dropped, that I was kind of like questioning whether I should drop or not, was oh, let me remember now. There was another one. Oh, the increased intracranial pressure one of the infant. Okay. A lot of you picked tachycardia. Usually they have bradycardia at first, but sometimes they do get tachycardic in the beginning and then they go bradycardic. But the answer was the sleeping a lot because I said the most common thing for ICP was level of consciousness. So you had to take sleeping a lot as is a change of level of consciousness for the infant. So you know, it's not going to just come out and say change in level of consciousness because that's too easy. So these questions are what are going to be on your NCLEX, and you have to critically think. Okay, if level of consciousness is the first thing that changes for increased intracranial pressure, that baby sleeping a lot, that's a change in level of consciousness. Okay, so when you are taking these tests, you've got to look at it when they say the priority. What's more important, getting those antibiotics started so the patient doesn't die, or making sure that you have seizure precautions ready? Well, yes, Tony.
I'm sorry, Ms. Shank. I have a question about that, and I am truly asking. So in my mind, I was like, we should do seizure precautions because we can't order the antibiotics. So while the doctor's ordering that, we should watch for seizures. Can you help me figure out how
Okay,
to?
so you can't think like that because as soon as that doctor knows that that kid has okay, so what did I say happens after we do the lumbar puncture and the blood culture? We immediately start a broad spectrum antibiotic and then we'll change it according to the cultures. So that doctor, before he even does that lumbar puncture, is going to already order those broad spectrum antibiotics.
So
Okay?
in cases like this on questions, we are like assuming that the doctor has already ordered these medications.
Yes.
Okay, thank
Yes.
you.
With that one though, didn't the answer say as antibiotics become available? Because that was why I picked seizure precautions, because I was thinking the first thing you're going to do is put them in seizure precautions, and then as the antibiotic becomes available, you'll give the antibiotic.
So maybe I need to take that available out of there. But I can see how you thought that. So I did take both answers. If you put seizure precautions or the antibiotic, I took both answers.
Thank you.
But okay, so I can see where the available threw you off, but it's still, antibiotics are more of a priority than the seizure precautions. You know? Um, so what was your thinking on increased intracranial pressure and that baby sleeping a lot? Did nobody pick that up as level of consciousness change?
I
I
was
did.
in between the two and I ended up doing seizure precautions, but I thought about it as a level of conscious change.
Okay. So again, I took both answers, but I mean, you just have to, think about it and think about it. Level of consciousness, the baby's sleeping more, so that's a change in level of consciousness. What about the dig toxicity question? Do we just not
I have a
remember
question
our
about
dig?
that.
What?
I have a question about that. So in the lab results, the DIDS toxicity was at the high end, but it was still within range. So that's why I didn't put that, because it wasn't
That was on the
within
second
range.
day, Tony. That was on the second day that they
Oh,
drew those labs.
so it wasn't on the day of. Okay. My bad. Thank you.
Is this the one with the bow tie?
Yes.
Okay, I chose Ditch Talks, but I don't know what I chose on this. I know I think so. I chose monitor heart rate for 1 full minute, and then was it the long PR
Yes.
interval?
It causes a prolonged PR.
Yeah, I choose that too. I think I chose the
I think I
D
might
on
have got that
that
right.
too.
Well, some people did get it right, but I ended up dropping it because the majority did not get the dig toxicity right.
I think
But
this is the,
Okay.
the only one
just
I think
know
I got dropped.
digoxin is a big drug on the NCLEX. You got to know the flush sheet that it gives you. I mean, that's a normal, that's not an abnormal, you know, but you get the nausea, the vomiting with dig toxicity. You can't give it if the pulse is low because it brings the pulse down. I mean, all those things, nitroglycerin and digoxin are two big drugs on your NCLEX. So, you need to know, especially those two. Okay. And always remember them. What else? There's 5 questions I dropped. There was another one that was all that apply that so there was the encephalitis, meningitis, the dig toxicity. I can't remember the other one I dropped. But again, it was a question that you really had to think about it and kind of analyze, okay, so I'm trying to get you guys to like critically think and that kind of stuff because you're going into what? Psych next, but after that, you're going into critical care. And I know the girls here in Sylvania that are in critical care are having a heck of a time, you know? So I was hoping to give you some questions that you really had to think about. But so with the adjustment, over half the class did pass. Okay. So you can go back in or I will be putting your grades in after class. So, but just be careful and make sure that the doctor has already ordered the meds. Make sure that you pay attention to what does sleeping a lot mean? Or, this thing mean, does it mean what she said level of, you have to just kind of think about what I say in class, and then it might be differently worded on the test. But it still is within the basic concept of what we talk about. Any other questions right now?
No, Miss Shake, but I wanted to let you know that I'm here.
Oh, okay.
I actually had another question. There was one that I felt like could have two answers. It was the one on oh, it was a cardiovascular disease.
The Kawasaki's?
Yes. But on that, the way the question was worded, if I remember correctly, it was like, what system are you going to monitor? And with Kawasaki's, you get the red hands and feet. So one of the answers was integumentary. Now, I didn't pick it because I know that Kawasaki's is a cardiac, but to me, I felt like that could have been either answer.
Okay, now there again, if you critically think, you were right in the way you answered it.
Okay.
Red hands and feet and the peeling of the skin is not going to cause any great harm.
Right, but it just said, what are you going to monitor? So then I was like, well, you technically,
But the
because when
heart
that
is,
goes
but
away,
the heart, because it can cause the aneurysm and a heart
right.
attack because of the coronary arteries, you always have to pick the biggest thing.
Okay. Yeah, because
The
I'm like, I know when the rash goes
gonna
away, they know
cause,
that it's over.
yeah. So
So
you
I
did
was just,
answer it right by going
okay.
that way, but that's how you have to think. What's going to be the worst thing that's going to harm this child? Well, it's the heart, so you better monitor that more. Okay? It's the priority thing. Okay.
Thank you. Sorry.
No, no, no. I want to help you guys. Because I want you guys to pass your critical care, your leadership, and I want you to pass your NCLEX. You know? All right. So we are starting on chapter 21, which is now urinary. So when we talk about little kids, with the kidneys, they're large in relation to their stomach. It's almost like they haven't grown into their kidneys yet. So they're more prone to injury. This is why a lot of people are really kind of upset on how we do competition sports for like, especially like elementary kids, you know, because sometimes they can get pretty aggressive, like soccer, football, and they're prone to injury because of those large kidneys. The urethra is shorter in both the males and the females, but it's more shorter in the female, of course, but because they haven't grown. Glomerular filtration rate is slower in infants. So the kidneys, if you remember back from A&P, the glomerular is where all the filtration rate takes effect. Okay. The water is reabsorbed into the body or taken out of the body. Your sodium, your potassium, all of those electrolytes are getting, the body says, oh, I need more of this. So the glomerular filters more back into the body. What it doesn't need comes out into our urine. So if if the rate is slower, that's what causes infants to have that greater risk for dehydration. Bladder capacity. 30 mLs in a newborn is all they can hold in their bladder. What is the adult? Anybody remember? Three to 500? 300 to 500 is an adult bladder. Um, Reproductive organs are immature at birth. They mature in adolescence when we go through puberty. Our common tests are the same as the adult. Now, the BUN and creatinine, what are you saying when you take, well, BUN, creatinine, and albumin? What are you measuring when you take those lab tests?
Kidney function.
Kidney function. 24-hour urines we do for protein, creatinine, or total protein. If you're low creatinine in your blood, you might be excreting that creatinine in your urine. So some of the problems, we are not going to talk about all of these. Bladder exstrophy is just the bladders on the outside of the body. We are going to talk about hypo and epispadias. Obstructive uropathy, something is just obstructed. Hydronephrosis, you've got like enlarged kidneys. And then vesico-retral reflux is when the urine goes back up to the kidneys. Okay, so the obstructive uropathy. So it's somewhere between the ureters, between the kidney, pelvis, and bladder. Okay, somewhere after the kidneys, we're getting obstructed. I am not going to specifically ask you the ureter, pelvic, vesicle, uretocele, all that. You just need to know that it's an obstruction anywhere from the ureters after the kidneys all the way down can be obstructed. This is the vesico-retral reflux. So it goes back up from the bladder, back up the ureters, and can get back to the kidneys. There's a valve that's supposed to keep the urine from going back up. Okay? So then they would need surgery to correct that reflux. Or what are these kids going to frequently have with this?
Is it gonna be bladder infections?
The bladder is putting the urine back up
UTI?
through the ureters to the kidney
Kidney.
infection. Okay? Bladder infection would be if we had an obstruction in the urethra. The ureters connect the bladder to the kidneys, so the backflow would be the kidney infection. The biggest ones off of this one that we're going to do is UTIs, nephrotic syndrome, and acute glomerular nephritis. Now, I believe I put the handout in there. I will double check to know the difference between nephrotic and glomerular nephritis. That is going to be a big one on the final. Knowing the difference, they got a lot of similar symptoms, but they are totally different. And then UTIs will be on your final. So kidney failure is pretty much the same as the adults. The child would have to go on dialysis while they're waiting for a kidney transplant. I do not go over any of these because you got these in OB. Okay. Circumcisions in the male. The one thing I want to say about this is that they have found that when you circumcise little boys, they actually have less DUTIs than an uncircumcised male. I do want to talk about this one. Testicular torsion happens in males 12 to 18 years old. They're not really sure what happens, but the testicles actually twist. It's very, very painful. So the kid's going to be like, oh my gosh. So you have to do immediate surgery, or you have ischemia to the testes, then it leads to infertility. Okay, so when we have GU disorders, these are a lot of the symptoms you're going to see. Burning on urination, changes in voiding patterns. Either you're not going enough or you're going frequently. Foul smelling or dark colored urine. Vaginal or urethral drainage. Genital pain, irritation, or discomfort. Blood in the urine, and edema. Edema is going to be one of the things we talk about with that nephritis and that glomerular nephritis. Masses in the groin, scrotum, or abdomen.
I'm gonna take a guess.
Flank or abdominal pain and cramps. Somebody stand up and show me where
am I
your
right?
flank pain is.
A little back. Okay.
Where, Brandon?
I see.
All right, so point to it.
Gotcha.
A little bit farther back. Right here, right where your kidneys are. That's flank pain. So if you see that someone has flank pain, they're usually having kidney pain. Distension in the lower abdomen, nausea, vomiting, poor growth, weight gain. Why would we have weight gain if we have a problem with our kidneys and stuff?
Is it fluid accumulation?
The edema. Yep, fluid retention.
That's the same thing. Fluid retention.
Fever, infectious exposure, and then trauma to our bladder, kidneys, or whatever. And then, of course, a lot of our drugs. Desmopressin, DDAVP. Does anybody know when we give that? What is a common time we give that?
Is it for diabetics and syphilis?
Which one?
Is it like diabetics and what is it called? The fluid retention for draining for diabetes and syphilis?
Actually, DDAVP is usually given for diabetes insipidus.
Yeah, that's what I said, diabetes insipidus.
Yeah, I can't hear very well, Stella. You got to be louder.
Yeah.
Yep, diabetes insipidus. But we also give it for bedwetting. Diuretics, corticosteroids, ACE inhibitors, and other antihypertensives. Tricyclic depressions we can use for bedwetting and uresis. And then, of course, suppressants we're giving when we do a kidney transplant. So when I worked PEDS ICU, we gave DDAVP like in the nose with drops.
I actually don't remember.
Is that how they're still giving it? Does anybody remember from farm? No one remembers their farm?
I really don't think we went over it in farm, if I'm being honest.
Oh, wow. And that's a big drug because you use it in
I think,
diabetes.
yeah, we did go over that in farm, but I forgot the way we used to give it because that's how when I remembered it from farm.
Putting it in the nose?
I
So,
forgot the route, but I remember going over DDAVP in the farm.
Oh, okay.
Yeah, but I forgot how the route to give it to.
Yeah. So a lot of different things we can do, which are pretty much the same as adults. Not going to test you on that. We're not going to do that one. Da, 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 da. I need to get down. All right. Bedwetting. So bedwetting is a problem, but we need to make sure before we start treating for bedwetting and uresis. Most of the time, doctors will not even start working on treating it until the child's like 8 or 9 years old. They can still consider bedwetting to be normal until that child reaches 8 or 9. Primary is the child never has achieved voluntary bladder control at night. Secondary, you used to have it, and now all of a sudden you're wetting the bed 3 to 6 consecutive months. Okay? Diurnal enuresis is daytime loss of urinary control. Nocturnal enuresis is bedtime wetting. Got that?
Yes.
So when we talk about bedwetting, because this is not the PowerPoint that I made. Oh my gosh, this is a really poor PowerPoint. I can't find the one that I remade. All right. So, like I said, 8 or 9 before they actually start looking into a physical cause for it. Um, and then they start doing all the different tests to see. But some of the things they do, of course, is limiting fluid before the child goes to bed. Another thing is if the child goes to bed at 8 or 9, the parents don't go to bed till 11:30. They wake the child up and take him to the bathroom before they go to bed. They actually make little pads that alarm. So as soon as a little drop of water hits the pad, it alarms and wakes the child up. One of the things that happens with kids is if they have sleep apnea, they are more likely to wet the bed because they don't wake up when they have a full bladder. Some kids just sleep really hard and don't wake up. That's why they don't do anything till the child's 8 or 9 years old and still wetting the bed. What is another thing that you might think of that's not actually physical that might cause bedwetting?
Night terrors.
Oh, night terrors would be a good one. But I'm thinking more on the
Is it
lines of,
abuse?
Abuse. I would think
yes,
it's abuse.
psychological.
Abuse,
Kids with, then it's
sexual
more
abuse.
of an abuse, or it could be neglect, or it could just be an actual psych problem, like, anxiety or something like that. So if it's not related to a actual physical problem, then a lot of times it's psychological that they wet the bed at night. We don't ever want a child to be punished for wetting the bed. So you need to teach parents that we just need to do things that so the child, eventually doesn't. But punishing the child is just going to hurt their psyche. They can't help it. They're not doing it on purpose. It's not like they wake up and say, "Oh, I'm just going to wet the bed for the heck of it and make mom clean it up." That's not how it works. So these parents who punish their kids because they wet the bed are going to hurt them in the long run, their psychological formation or mind. So we really want parents to not do that. So
Miss
now
Shank, what about constipation?
that can sometimes, because sometimes when you're constipated, you can't pee. And so then your bladder's going to get really full, and then it's going to leak because the urine has to come out eventually.
Yeah, I'm only saying that because my son had the bedwetting problem, and they put him on Miralax. He pooped, normally, but he was constipated in a sense. So they started him on like Miralax every day, and it fixed the problem.
Yeah, so sometimes when you have a lot of stool down there, it pushes on your urethra and your ureters and all in your bladder and all that. And so it can't empty because it's getting pushed shut. And then the bladder gets too full, and then it starts leaking out. Or when he sleeps, it relaxes and finally comes out. All right, I'm gonna see if I can find the picture. Wish I had my other computer. You know what? We're gonna take a break. I'm gonna try to see if I can find that other PowerPoint. Because we need to go through epispadias, hypospadias, and the glomerulonephritis and the nephritis. So take a quick break. All right, I found it. So there's two for this chapter. The one that says PEDS in front of it is the one that I redid. Because as you can see, that Lippincott one was terrible. All right, so we did that one. We did that one. We did that one. We did that one. Okay. Just so you can see what bladder exstrophy is, I'm not going to put this one on the test. But that's what it looks like. The bladder is on the outside of the body, just like when we have spina bifida, and the spinal cord is on the outside of the body. Okay, so hypospadis and epispadias. Sometimes it's a birth defect where the whole of the meatus in the male is not at the tip of the penis. Okay? Now, when they're infants, it's not that big of a deal. But how do you potty train a child when their meatus is on the top of the penis or on the bottom of the penis? It would be very hard to have them urinate in a urinal or the toilet that way. And then also just because of the way it looks. So they do have to surgically bring the meatus out and make a hole at the tip of the penis. Okay? So hypospadias, it's underneath. Epispadias, it's on the top. So they call it the ventral side for hypospadias and the dorsal side on top for the epispadias. So, postoperatively, we have to assess the urinary drainage from the urethral stent or drainage tube, so that we can, they will have, we got to make sure they're still urinating without putting stress along the surgical site. Make sure that the urinary tube remains carefully taped with the penis in an upright position to prevent stress on that incision. And then we have a compression dressing so that we reduce the edema and the bruising. So the biggest question is going to be the hypospadias is on the ventral surface, the bottom, and the epispadias is on the top, which is the dorsal side. And then that we have to have it corrected for the child to be able to be potty trained. Those are the biggest questions that will be about that. Hydronephrosis is when the calculus and the pelvis of the kidneys are enlarged, and then it's usually a congenital defect. And then, as you can see, then there's an obstruction in the ureter. It can be secondary because of the obstruction, and then it enlarges the pelvis and calculuses of the kidneys. Okay, I'm not going to go through that again. Let's see. Okay. So, these are on the test. Nephrotic and glomerular nephritis. Nephrotic syndrome occurs as a result of increased glomerular basement membrane permeability. So it's allowing things to get through to be excreted in the urine that shouldn't. It should be going back up into the body. So we can have congenital, they're born with it. Idiopathic, they have no idea. and secondary caused by some other disease. So they are losing protein, albumin, in their urine instead of it going into the body. Therefore, they have proteinuria and they have albumin in their urine when you test their urine. That makes it, because it's coming out in the urine, if you do a blood test, they're going to have decreased protein and albumin in their blood. So the protein loss is, which is, the albumin is one type of protein, is the biggest thing that happens in nephrotic syndrome. So the hypoalbuminemia, which if you look at emia, that means low in the blood, results change in osmotic pressure. Fluid shifts from the bloodstream into the interstitial tissue. These kids have edema. The decrease in blood volume triggers the kidneys to respond by conserving sodium and water, leading to more edema. The liver senses the protein loss and increases the production of lipoproteins. Therefore, they get hyperlipidemia. So with nephrotic syndrome, they're going to have edema. They're going to have protein, albumin in the urine, and then they're going to have hypoalbuminemia because they lost it in their blood. So in your book, there should be I guess I don't. I thought it was in here. I thought there was a little table that gave you the difference, but we'll go to my handout in a minute. But for nephrotic syndrome, nausea and vomiting, recent weight gain because of the edema, the biggest one is periorbital edema upon waking. Periorbital edema upon waking. What's periorbital edema? Yep. And then through the day, it progresses to generalized.
Edema around the eyes.
But it seems to be in the face and the eyes when they first wake up from laying down. Weakness and fatigue, irritability and fussiness. So on the blood or the urine, remember they're going to have proteinuria. The blood test, they're going to have low protein and albumin in their blood, but then they're going to have high cholesterol and triglyceride levels in their blood. the problem with nephrotic syndrome is they can get better and then it can always come back again. When they're actually having the nephrotic syndrome, they need increased protein in their diet. And we need to make sure that we are preventing infection. So treatments are corticosteroids. If they're severely edematous or they're in hypoalbuminemia and their albumin in their blood is very low, we may give IV albumin. And then, of course, we're going to give diuretics during the edematous phase to try to decrease the fluid. Lasix is usually the first one that we give. They also require potassium supplements. So we're going to put them on a high protein diet, potassium supplements. We're going to give them Lasix, corticosteroids, and then if it's severe hypoalbuminemia, we're going to give IV albumin. And the biggest thing with this one is the periorbital edema upon waking that then progresses to generalized edema. Blood pressure is most likely usually normal. Acute glomerular nephritis is post-strep. Remember, we had rheumatic fever, scarlet fever. Strep is not a good one to not be treated when we have strep throat. So it's acute post-strep glomerular nephritis. It's an immune process that injures the glomerular from the strep. Causes inflammation, which alters then the function in the kidneys. Now, in glomerular nephritis, they're going to have blood and protein in their urine. And then these kids are going to be hypertensive. If there's evidence of a current strep infection, then we're going to give antibiotics. But if it's already past that, then we just have to treat the glomerular nephritis. So in glomerular nephritis, you're going to have fever, lethargy, headache, decreased urine output, abdominal pain, vomiting, anorexia, hematuria and proteinuria, edema, and elevated blood pressure. So, with nephrotic and glomerular nephritis, you're going to have the proteinuria, the edema, the vomiting, the fever, and the lethargy. Those are all going to be in both. But in the nephrotic, you're going to have the high cholesterol, the hypoalbuminemia, and the periorbital edema, which gets worse upon waking and then becomes generalized. In glomerulonephritis, you're going to have the hematuria and the elevated blood pressure. Those are specific to glomerular nephritis. So the treatment for glomerular nephritis is antihypertensives, diuretics, sodium and fluid restrictions. They can go back to normal activity when the protein in hematuria in their urine is resolved. Okay, so this is the testicular distortion we talked about. So when we are doing, meeting a child with these problems, we need to know their past medical
Excessive
history.
like fluid.
Maternal polyhydramnios and oligohydramnios. Either, what is polyhydramnios?
Oh, amniotic fluid.
What
Yeah.
kind of fluid?
Is it like overhydration?
Amnios. AMNIOS.
Oh, amniotic fluid.
Amniotic fluid.
Yeah.
So if mom had too much amniotic fluid or not enough amniotic fluid, these are the kids that are born with congenital urinary problems. Then if mom had diabetes, hypertension, alcohol, or cocaine ingestion, any of those things can make the child more prone to having urinary disorders. Family history. Okay, we did that one. So when we are trying to restore fluid and electrolyte imbalance in any of these disorders, we need to monitor vital signs frequently and assess urine-specific gravity. What vital sign is most important to kids with kidney problems? Or anybody with kidney problems? Which are your vital signs?
Wait.
Blood
Blood pressure.
blood pressure.
The daily weight.
Blood pressure.
Blood pressure. Okay.
Blood pressure, that renin-angiotensin cycle that relates to the kidneys. Blood pressure is a big sign, hypertension, that something could be going on with the kidneys. So the diet, such as with nephrotic syndrome, we have to give potassium and increased protein in their diet. With the glomerular nephritis, they're on a sodium restriction and fluid restriction. So any of them need to have strict I&O. Diuretics as ordered. When urine output is restored, diuresis may be significant because all of a sudden now their kidneys are better, they're working, and all that fluid in the body, that edema, has to come out. Monitor signs of hyperkalemia, hypocalcemia. What is hyperkalemia?
High potassium.
And what is the number?
Anything above 5 or 5.5?
You know, this is one of those ones where I guess it just depends on
3.5.
where
Yeah.
you work. But it's some places say 4.5, some places say 5.
5. Okay.
So I've seen it either way for the high end of potassium. And then packed red blood cells if we need them, albumin IV if we need it, and then dialysis. So let's go to the handout.
Miss Shank, are you able to upload this PowerPoint for us so we can
I
use
did
it?
already.
Okay, thank you.
That's why I said if it says PEDS in front of it, then it's the one I did.
Okay, sounds good. Thanks.
The other one is the Lippincott one. Oops, I did. Hold on. I went into the lab instead of the class. Where's my... Let's see if I put it in week 3 or week 2. I didn't put it in week 2 because we were supposed to do this chapter in week 2 and we didn't get to it. Yep, it's under week 2.
Okay.
So, unfortunately, it might be better to print it because, this is the way it uploaded sideways. But it's got the difference between nephrotic and glomerular nephritis. Okay? So it's got the symptoms here, like, here's the hematuria. You may see it in nephrotic, but usually not. But then when you get to nephrotic, you've got a 3+. So you got a lot of it in here. Okay? The only thing I don't see on this chart is the blood pressure. So you might want to add underneath it, nephrotic blood pressure is usually normal. In the glomerular nephritis, they get hypertension. And that'll be an easier way for you to remember the difference between nephrotic syndrome and glomerular nephritis. So, nephrotic is nephrotic. Nephritic is your glomerular nephritis, your glomerular. It doesn't say glomerular in front of it. Well, I didn't find that one either, so we're going to have to use Lippincott's. So the next chapter is neuromuscular or muscular disorder. So motor development begins at birth and then predictable sequence. Full range of motion is present at birth. Spinal cord is more mobile, and myelinization does not occur until 2 years of age. The skeleton is not completely ossified until late adolescence. Growth of bones occurs primarily at special growth plates at the end of the long bones. Children's bones are more vascular and heal faster than adults when they do break. All right, can you see the whiteboard? So the
Yes.
growth plate is at the end of all the long bones. That's supposed to be my bone. And it runs along here, okay? This is not closed off because it allows the long bones, the tibia, no, the ulna, the radius, the humerus, the tibia, the fibula, and the femur in the leg to grow as the child grows. So the biggest problem is if they fracture at the growth plate. Depending on how big the fracture at the growth plate is and how much damage is to that growth plate, the bone will not continue to grow as the child grows. And then what they have to do is they have to, as periodically, they have to break the bone, let it heal to grow, and then later on take the child back to surgery again, break the bone again, let the bone fill in so that it grows. And sometimes, even with doing that, the bone never grows the same length as the other bones. But so this epiphyseal plate, growth plate, is a big deal when we talk about fractures in children. Testing's all the same. Lab tests are the same. So this is where they include the chapter on the neural tube deficits, the spina bifida, the myelomeningocele, and the meningeal seal. Club foot, hip dysplasia, torticollis, and then osteogenesis perfecta or muscular dystrophy are all in this chapter. So this is your myelomeningocele. The entire end of the spinal cord is on the outside of the body. Then we have occulta, which is either a little dimple or a tuft of hair. Meningocele, some of the spinal cord is out, but it doesn't have the nerves are out in it. And then in myelomeningocele, everything is on the outside. The nerves and everything. And these are the kids that are paralyzed, usually from the waist down. Scoliosis, and then fractures, trauma, all that good stuff. Cerebral palsy is usually a motor disorder in childhood. It's lifelong impairment. the higher incidence in your premature and low weight infants. But anytime a infant goes without oxygen in utero or during the birthing process, they can get cerebral palsy. There are different types of cerebral palsy. They can have spastic, dyskinetic, ataxic, and mixed. So that is on page 769, the classifications of cerebral palsy. The biggest thing with cerebral palsy that we need to be dealing with is physical, occupational, and speech therapy. Okay? Did I open the right one? Hold on a minute. What's urinary genital? Hold on. It doesn't look right. Oh, wait, I couldn't find mine. That's right. Okay. So we're making sure that they don't get contractures. So using splints, leg braces, okay, orthotics, and doing physical, occupational, and speech therapy. It's multiple disciplines have to take care of this child. And then we need special seats for them, special car seats, regular seats for them to sit in, bath chairs for them, because they do not have the muscle control. Some kids will have developmental delays. And spasticity or rigidness of their muscles. They're not going to do spinal cord injury. Muscular dystrophy. The muscular dystrophy is a disorder that affects voluntary muscle control. It's not always evident at birth. It shows up a little later as the child starts to walk and starts to move around, and then we start noticing that there is a problem with their muscles. There are different types of muscular dystrophy. Those are all on page 762 in your book. The only one I'm going to test you on is Duchenne's. It limits their lifespan because eventually it affects the muscles of the heart and the lungs. So Duchenne's muscular dystrophy is fatal. You notice it in early childhood, and Duchenne's muscular dystrophy is an X-linked recessive disease. So usually only males have it. It starts in their limbs and their trunk, and then it ends up going to their lungs and their heart and everything else. So with Duchenne's muscular dystrophy, they do something we call Gower sign. And because of the weakness in their legs is where it starts first, this is how they have to get up when they're sitting on the floor to standing. They can't just stand up. So that is one of the signs of Duchenne's muscular dystrophy, Gowers. Gowers. So these are the kids with Duchenne's muscular dystrophy that we want to make sure that they have the best life possible before they do succumb and it becomes fatal. These kids usually will live into their early 20s, and that is the max. The saddest part is there's nothing wrong with their brain. It's just their muscles don't work. Scoliosis is another one that will be on the test. God, why can't I find my PowerPoint? Makes me mad. So scoliosis is that S lateral curve in the spine. If it's greater than 10 degrees, they diagnose scoliosis. It can be congenital, associated with other disorders, or acquired. Braces and surgical repair for severe cases. For the orthotic, they don't ever use the Milwaukee brace anymore. But these are usually, we call them turtle shells orthotic braces. This is what they look like. And the child wears this brace. And then they gradually change the brace to straighten out the spine. If it is severe or they can't straighten it out, then we do rods. One of the rods is the Harrington rod, or there's other kinds of rods that they put in the back to straighten out the spine. This is a major surgery when they do this. When you have the surgery and you have the rods in the back, we have to keep the child straight. So when we roll them, we need at least 2 or 3 people, because they're teenagers when they get this done, because you have to log roll them. You have to roll them as one unit, or you will bend the rod and, ruin the surgery. Body image is a big problem when they have scoliosis. One of the things you note is that one shoulder is lower than the other, or they're bent over. Hip elevation on one side is another thing you might notice. What we do is we have them bend over, and you can see that the spine is not straight, and then it's curving out to one side or the other. In the olden days, when girls had to wear dresses, it was a little easier, because if you looked at the child, the hem of the dress was not straight. But that's how we notice that the child has scoliosis. And then, depending on the degree of the curve, they will either use the orthotic brace or they will have the rodding surgery. We want them to have a positive, image of themselves. So we can make those orthotics look really pretty. They can be all kinds of colors and stuff. We want them to wear it. They have to wear a shirt under the orthotic so that they don't get skin irritation. So I'm not going to actually test you on the Salter-Harris classification syndrome, for the epiphyseal plate. But I want to show you the picture in your book, because this will determine on how much damage is to that growth plate, that epiphyseal plate, to whether it's going to heal and the bone can still grow. That's on page 780. The only thing I will question you on is that certain damage to the growth plate or epiphyseal plate can make it so the long bones can't grow as the child grows. So when we are assessing the child, we want to make sure that, we notice a change in gait, clumsiness, they're not up to activities or the developmental level physically for gross motor development to their peers, recent trauma, poor feeding, lethargy, fever, weakness, alteration in muscle tone, and those developmental milestones. Are they meeting them? We also check, reflexes. Okay. The next thing I want to talk about is the type of fractures. Okay. A green stick fracture is an incomplete fracture. How many of you have maybe gone out and toasted marshmallows with a stick? Anybody? No? Somebody has.
Yes.
Okay.
Yes.
Yes.
So you
All
took
the
that
Yes.
time.
branch that you were going to toast your marshmallow with. If you break it and it snaps easy, it's dry, right? And it breaks easy. Well, if it's green and it's still like you took it off the tree and it's still like living, it's like green in the inside and you can't break it in half, can you? So kids get what we call green stick fractures. They don't break all the way through. Their bones are not ossified all the way. So they don't break all the way through. So green stick fracture, where it's not all the way through, is the most common fracture in children. The other type of fracture we have to talk about is a spiral fracture. A spiral fracture is because the bone got twisted. What do you think is the most common cause of a spiral fracture?
Abuse.
Child abuse. Okay? The parents twisted, and it's a spiral fracture. So, spiral fracture, we automatically think abuse. Okay? If there's anything else we need to make sure we go over. Hip dysplasia. Did you guys learn anything about hip dysplasia in OB? Or your pediatric assessment? Okay.
Tortellini.
What?
Is that like the tortellini or
Order.
however you
Yeah.
tortellini?
Yes. So we are checking that at birth, but it could not, it usually shows up at birth. The ball of the hip is not staying in the socket. Okay? So when you push their legs up and then bend them out at the hips, you hear a click or Delaney sign. So the other thing is if you stand the child up, he's going to have extra folds on the leg that isn't out of socket, and then the other leg's not going to have as many folds at the under the butt, and it's going to be longer than the other one because it's not in the socket. So these kids, we usually have to put it back in and let it grow around it so that it eventually stays in the socket. It depends on how bad it is to how long the child has to stay in the Pavlok brace. Pavlok brace is the number one way that we do it. This is the picture in your book showing the ortolanes, and when you stand up, the extra skin folds and the leg longer. Page 759. This is a picture of the Pavlok brace. So it's keeping the hips in abduction or adduction. Abduction. Abduction is away, adduction is bringing it together. So we keep those hips in abduction until the child's muscles and bones will keep the socket in the hole or the ball in the socket. Okay. Another way of doing it is back with cloth diapers, we would triple diaper the child with cloth diapers, and that would keep them in abduction. This needs to stay on at all times, but you do have to make sure that we take it off once in a while, and check on, their skin to make sure there's not an issue with irritation. Okay. I believe that's all that oh, wait, no. Let's do club foot one more. Because I do believe that club foot is on your test. Maybe not. I don't see it now. All right. Well, I guess clubfoot's not. Okay. So those are the disorders out of this chapter. There's plenty more in this chapter, but that's all you're required to know out of this chapter. We're not going into all the tractions. We're not going into spinal cord or disorders. Okay. All right. Let's go to lunch for a half hour and then we will do the next chapter. It would be 23. All right. See you in a half hour. Everybody back? Most everybody?
Yep.
I'm
The,
back.
the one thing I forgot to do is you guys are supposed to do a survey on your lecture like you did for the lab. I'm supposed to post it in Brightspace for you to then be able to take it. And I forgot to do that, so I will do that as soon as we're done with lecture. Supposedly, you're supposed to show someone that you did it. Who's on campus tomorrow? Anybody? Okay, so some of the groups. If you could show your lab instructor or Miss Missy that you did the survey, or tell her you did it, so I can have names on how many I'm supposed to put, how many students out of this group actually did the survey. They would like to have 100% for APAS. So as many of you as can get it done by the end of the week, that would be great. So I'll get that posted. Um, we are on chapter 23. It's a very short chapter because I don't go into the stuff that's the same as the adults. So, infantigo.
Excuse me, Miss Shan.
Yes.
So when you don't go over something that is same as adult for the exam, do we still study it for exam?
If I have it on the study guide, but I'm not going to do pressure injuries or burns on the test. Definitely not. I'm not going to do acne on the test. I don't do, yeah, no, most of the time, no. The only time it is going to be is a little bit when we do asthma, when we did asthma, and then when we do insulin on Thursday, or I mean diabetes, because diabetes is on your final. Okay, so infantigo is something that kind of spreads like wildfire in children. They're papules and they progress to vesicles, then painless pustules, and then they kind of like pop and dry out. It's a honey-colored exudate when the vesicles or pustules rupture. Then it forms a crust on the ulcer-like base. It's caused by staph or group A beta hemolytic strep. So group A strep or staph is what causes it. They are contagious until everything crusts over and there is no more drainage from anything. It tends to be on the face the most because what do kids do? You know? But they cannot be around other kids, just like chicken pox, when there is the pustules or vesicles and they're draining, because then they will spread it to the other kids. Treatment is topical with mupirocin ointment. If numerous lesions, they might give them oral cephalosporin in addition to the topical topical ointment. Clindamycin if it's methicillin resistant staph. Putting a cool compress on the honey colored crust twice a day helps to not only heal them, but it's more comfortable for the child. And just like I said, they can't be around other kids until everything is scabbed over. Viral rashes, this, I'm not going to test you on it, but you know, we just have different kinds of viral rashes when they have a virus. Okay, ringworm. Ringworm is a fungal infection. It's not a worm. We don't know why they call it ringworm. But anyway, they're all tinea. Tinea. Ringworm is tinea. What comes after it is where it's located. So tinea capitis is on the scalp. We use selenium sulfide shampoo to decrease the contagious and help get rid of it. Oral, whatever this is, for 4 to 6 weeks. No school or daycare for a week after treatment starts so that it doesn't get spread. Tinea curis is jock itch. It's in the groin. Topical antifungal preparation for 4 to 6 weeks. It takes a long time to get rid of ringworm. Tinea pedis is athlete's foot. Okay? Ringworm in your feet. Tinea vesicolor is hypopigmentation lesions on the upper body. Tinea corpus is when it affects any other part of the body. Antifungal cream for at least 4 weeks to get rid of ringworm. So she has it
Hey,
on her face. He has it on his scalp. What?
hey, Professor Shank. This is Brandon. Sorry, my computer restarted. I didn't realize you started back.
Oh, okay. So this is scaling of the scalp, central hair loss. Which one of the tinnias is this one? It's on his scalp.
D.
D, capitis, like putting on a cap on your scalp.
Yeah. Mhm.
Okay, we're going to talk a little bit about diaper rash and candidas. Contact dermatitis, okay? So diaper rash is usually because they're not changing the diaper often enough. In the old days, we used cloth diapers and rubber pants over the cloth diapers. That tended to cause a lot of diaper rash. Using harsh soaps. You really should use baby wipes that are fragrant and preservative free. That will irritate and give the baby a diaper rash. Once the rash has occurred, we want the baby to be air dry. Go diaperless. Let them air dry. Blow dry the diaper area with a dryer set on really low. That'll help dry it out. And just making sure you clean the area and change the diaper. Not gonna do that one. Contact dermatitis, atopic dermatitis. Okay, I'm sorry, not contact. Atopic dermatitis is eczema. You might have learned it in with the adults, but it's more common in kids. It starts in childhood. Then it just continues to go into adulthood. Extreme itching, inflamed, reddened, and swollen skin. With or atopic dermatitis, you don't want the kid to be like in bubble baths or stay in soapy water. The best thing to do for them with it is as soon as they get out of the bath, don't dry them all the way and apply lotion Or like, oh, what is that one cream that starts with an H?
Hydrocortisone.
No, this is over the counter. But we do use hydrocortisone if we can't, if it gets severe, yes. I don't know. Anyway, there's stuff out there, but it's really not just watery lotion. Because when you keep moisture in after they're wet, you keep the moisture in, it helps with their dermatitis. Other things that irritate the dermatitis are your alcohol-based hand sanitizers and soaps that are anti-infective. The only thing I want to say about burns is that when you are taking care of a child with burns, before you do anything with them, they need to be medicated with morphine. So, atopic dermatitis, diaper rash, infantile, and ringworm are the only things you are going to do out of this chapter. Holy crap. How many chapters do we have to get through here? All right, we're going to just barely touch base on 24, and then we'll finish it on Thursday. Well, that chapter's pretty short and easy.
Is the final like comprehensive, so old stuff and new stuff?
Yep. And I'll tell you right now, Erickson's and Piaget. You better know your Erickson's and Piaget. So this just goes over our blood cells. Do we need to review this? You should pretty much know it by now. Okay, so anemia. We have nutritional deficiency. Can be iron, folic acid, or pernicious anemia. Toxic exposure, lead poisoning. Aplastic anemia, hemolytic anemia, which is your sickle cell and thalassemia. Iron deficiency anemia. Iron deficiency anemia is because we do not have enough iron to produce hemoglobin. When you have iron deficiency anemia, anybody know your symptom?
Tired, cold,
Pale. Okay? So the child's going to be pale. They're going to get tired, short of breath. They fatigue easy. What was the other one you just said? Cold. And they're cold because they don't have that blood and oxygen getting transported. So some of the common causes of anemia, iron deficiency anemia in the child, is maternal anemia. I think we talked about this, how mom gives her iron supply and her hemoglobin to the newborn. So, and if you remember from newborn OB, when they're first born in the first couple of weeks, their hemoglobin's quite high. Then all of a sudden, around 2 or 3 months of age, their hemoglobin drops, and then their body has to start producing it themselves, and then their hemoglobin goes back up. If mom is already anemic during pregnancy, then the baby's not going to get the hemoglobin and the iron supply from mom. Poorly controlled diabetes during pregnancy, prematurity, low birth weight, and multiple births. This is a big one for your toddlers. Cow milk consumption. Cow's milk is a poor form of iron. Hold on. Okay, so because it is a poor consumption, when they go off of formula and go on cow's milk, some kids want to just drink milk, and then they don't eat their food. So around toddler age, they become iron deficient anemia because they drink too much cow's milk and don't eat enough food. Infant consumption of low iron formula, or mom is breastfeeding and mom's not getting enough iron. Okay. All formula should be iron fortified. That's, an FDA thing. But if they're buying some kind of cheap brand that doesn't have enough iron in it, it's going to give them that. So that's the breastfed. Okay. Excessive weight gain. If the baby gains a lot of weight, infection, blood loss, a restricted diet, use of medication interfering with iron absorption, such as antacids, low socioeconomic status, they're not getting foods with iron, and recent immigrants from developing countries because they probably don't get enough iron in their diet. So these were the symptoms we talked about. So the fatigue, weakness, pale skin, lips, and nail beds, irritability and mood changes, poor appetite, and cold hands and feet. These are your signs of iron deficiency anemia. Rapid heartbeat, dizziness, lightheadedness, headaches, pica. Pica is craving for non-food items such as dirt or ice. Has anybody heard that before about chewing on ice? It's a sign of
Yes.
iron deficiency anemia. If people who crave chewing on ice, they're usually anemic. But kids will eat dirt trying to get iron out of the dirt. And then it causes delayed growth and development. So we got to make sure that we're keeping an eye on these kids. giving them iron supplements when they need it. Because iron deficiency anemia is the most common in the kids, it will be on the test. Now, when we are giving iron supplements, does anybody know some special things that we have to do when we give iron?
Give it slow.
With calcium.
Okay, we can citrus juices help it, yes. What was the other one?
Depends on how we're giving it, but we should give it
Give it with
slowly
orange juice.
if we're
Well, we want it to go past their teeth. Iron stains teeth. So the best way to give it to a child is through a straw. So it bypasses their teeth. If you can't do that, then you must immediately brush their teeth after you give them liquid iron or they chew an iron tablet. If they can't swallow it, we need to either use a straw or brush their teeth immediately afterwards. What else does iron supplements cause?
Mm-hmm.
Black stool.
Yes, it causes constipation and black stools. So we may need to put them on some kind of stool softener. And then you can overdose on iron, so make sure all iron tablets or liquid are out of the reach of children. Okay, we're going to go into lead poisoning next. I saw you guys had a lot of questions on your ATI on the lead poisoning. So, pernicious anemia, I'm not going to test you on, but you should have learned about pernicious anemia. What is pernicious anemia?
B12 deficiency.
B12, yup. Then you got to get B12 shots. Okay, so lead poisoning. Lead poisoning is a big deal because kids eat paint chips. Because we shouldn't have it in the family or in the paint anymore, but we do. I think I told you about the crayons that my kids, or that some kids were having, not my kids, that came from China and they had lead in them. So, low levels of lead poisoning give behavior problems and learning difficulties. Higher levels cause encephalopathy, seizures, brain damage. When they're higher levels, we have chelation treatment. It is now given IV, thank God, because when I was first started, we gave it IM, and it's very, very painful IM shot. We had to put ice on their thigh for an hour to numb it to be able to give them their chelation treatment. So prevention from lead is the best way to do it. And then the chelation therapy. Make sure they have adequate fluid intake and monitor I and O when you are giving them the chelation therapy. What it does is it binds to the iron and pulls it out of the body. Sickle cell anemia. I'm going to talk briefly about thalassemia, but I won't go into detail on thalassemia. Sickle cell anemia is the big one. So this is from Africa. And I don't know how much you guys know about sickle cell anemia. Did you learn anything about it yet? There's a reason why African descent have sickle cell anemia. Does anybody know? Malaria is big down there in the jungles, okay, from the mosquitoes. Especially before we had mosquito, we're talking like the 1800s, early 1900s, probably before that even. Way back when it was a genetic mutation. So what they found was people who have sickle cell anemia do not get malaria. So, survival of the fittest. People with the sickle cell disease are the ones that survived, continued on, and kept passing the genes on. So that's how it got started. It was a genetic mutation way, way back when, and these people survived because for some reason they can't get malaria. So with sickle cell, what happens is the sickle cells clump together and they cause a clot like in the blood vessels. There is a picture in your handouts that shows all the sequelae that can happen with a child with sickle cell anemia. I thought I had more on it. Okay. So they can have a lot of sequelae because of these crises. So when they go in crisis, because all their sickle cells are clumped together, we need to be giving them pain medicine, usually a PCA pump. They are in a lot of pain with their joints. We then have to give them a lot of fluid to try to flush those cells apart. It is a genetic disorder. We want to prevent a vaso-occlusive episode when they clump together. One of those is making sure the child does not get dehydrated. When the child gets dehydrated, their cells are more likely to clump and they go into crisis. Oxygen should also be given during a crisis because they need more oxygen because the sickle cells don't carry as much oxygen. It affects their spleen, and sometimes they need to have their spleen removed. We need to make sure that these kids get their immunizations because infections can also cause them to go into crisis. We need to keep track of their hemoglobin, their platelet count, so their SED rate may be elevated, abnormal liver function test. Hemoglobin is usually low. There's also a picture in your book that shows all the things that can happen because of these crises. The more the child goes into crisis or the more frequent, the more likely they have this sequela. They can have a stroke, retinopathy, blindness, or hemorrhage in their eyes, enlarged liver, enlarged spleen, hematuria, diluted urine, I don't know, PRIAPISM. I believe that is painful erection. Osteomyelitis and chronic leg ulcers. Those are all complications. When they have a sickling and it's affecting a joint, their joints are swollen, painful, they're warm to touch. Because it affects every system, we need to be aware of anything that's different going on with them. There's a lot of new treatments out now. There's a new one where they're injecting some kind of DNA, and I guess it's having great success because then the body is producing normal cells and not producing the sickled cells. So just keep an eye out on, new things because it's in the study stages right now, but we're hoping that it comes out there and then we can actually cure sickle cell. Anybody know anybody with sickle cell anemia? Anybody ever take care of a child? Oh,
Yes.
Yes.
My god sister, she had sickle cell anemia. I think she died at she was
if you've
in her
ever been
30s. I think she
around
passed
one
away.
when they've been in crisis, it is horrible.
Yes.
It is so hard to watch them be in so much pain
Yes.
and not grow properly and all kinds of things. So I'm hoping that these studies they're doing now work and we can actually get rid of sickle cell anemia. Thalassemia, the only thing I want to tell you about thalassemia is it's mostly in Mediterranean descent, and your blood cells are more of a square instead of being round. And the only treatment is blood transfusions. They get rid of all the square cells and give them blood with the round cells. The only one out of these that we're going to do is hemophilia A, factor VIII deficiency, and idiopathic thrombocytopenia purpura. Those are the two clotting disorders which we will pick up on Thursday. Now, what I'm going to try to do is I'm going to do like a review with some questions from ATI so that you can kind of see the questions and how to answer them. As soon as I get that done, I will let you know when I can offer you tutoring or a review extra outside of class. Okay? So as soon as I get that thing up for the lecture survey, please try to get that done this week. If you have any other questions, I will be contacting people who have failed the test to set up for a review.
Are you gonna do a study guide like you have for the last couple tests for the final as well?
Yes, but I just printed my old final, and there's quite a few questions I have to either change or drop. So as soon as I get that done, I'll be working on that today and tomorrow.
Okay.
And I'll try to get that up too. And then I'll try to get some kind of review together.
I really appreciate it.
Okay. All
Yes,
right.
thank you.
Thank you.
Have a great day.
Thank you.
you.
Mhm.
Thank you.
Mhm.